Greetings, everyone. My name is Jean-Pierre Kikens, and I'm very pleased to welcome today for this interview Dr. George Farid. Welcome, Doctor.
Thank you very much, Jean-Pierre. It's a privilege to be interviewed by you today. And congratulations on all of your reports that impact doctors like myself in a very positive way and very informative. And I'm really honored to be interviewed today. Thank you.
The honor is mine. Thank you so much for your kind words. Dr. Farid has a distinguished medical career spanning some 50 years. He graduated from the prestigious Harvard Medical School in 1970. He held teaching positions at Harvard, at the University of Nice in France. Monsieur le Dr Farid parle le français également, and at the University of California in Los Angeles, UCLA. His career comprised both extensive research and clinical practice. His research covered areas such as enzymes for DNA recombination, antigens, AIDS, and cancer. His clinical work covered mostly family medicine, sports medicine, and AIDS. He presently practices in Southern California, in Brawley, and in El Centro, and he has already treated hundreds of COVID-19 patients since March. At his practice at the Pioneers Health Center in Brawley and at a nearby nursing home. And I'd like to start maybe with a picture of a class of 1970 from the Harvard Medical School. How do you feel about medicine today as compared to when you studied at Harvard?
Well, I feel that medicine has evolved extraordinarily in ways I would never have envisioned, never dreamed of back then. I'm an old timer. That was 50 years ago. And I was enamored with medicine then and inspired, and I wanted to make an impact in some area. I didn't know where, but I thought that my calling was more in research than in actual clinical practice. And 30 years ago, that I changed and went back into full-time clinical practice. And now I've enjoyed catching up after a 20-year lapse, which wasn't easy, but being able to join in and do my residencies basically right there out in the trenches here in an underserved area of Southern California on the border with Mexico. But in any case, it was a time of wonder for me, and in those years, and I was very fortunate to be educated where I was and to have the inspiration of all that went on in the past in Boston and at Harvard, so that I hope I'm not disappointing the people who had confidence in me in those years.
So do you think we are much better prepared today than we were 50 years ago for a pandemic like this one?
Well, we definitely are much better prepared than we were 50 years ago, and we'd have to look back at the pandemic of 1918 and in how unprepared the society, the world was for that, and the high fatalities that took place and devastation. Fortunately, we aren't at that level by any, and it's a consequence of our advances in every aspect of medicine and in society today.
Yet, and we'll go into more details later on, but the medications that you are using today were existing 50 years ago.
Well, it wouldn't have been known at that time. I think we were starting to use hydroxychloroquine at that time for, of course, for malaria treatment, and then looking at it, I don't even recall it being recommended for rheumatoid arthritis in my medical school days or in my internship. However, it very well may have been by advanced rheumatologists. And however, we wouldn't have thought of that type of medication having other indications or potential. We have such a great knowledge of molecular functions and actions of agents that we didn't have then, that helped us to certain people that recommended that it be employed in the current pandemic for use that we didn't have at that time and 50 years ago.
Interesting. So in February, when the word came out that there could be millions of deaths with this pandemic in the US alone, what was your reaction?
Well, my reaction came actually a bit later in March, or when in February I actually was on an extraordinary trip in the Sea of Cortez. I was watching with dismay what was going on in China, in Wuhan, and how the Chinese were handling the horrible epidemic there, and appreciating what we're trying to do to ward it off here in the West and the United States. But I was actually with my wife. We were avid scuba divers, and we went down to Loretto and dove where Jacques Cousteau used to love to dive, and we were on a sailboat called the Zeppelin. That was a dive and sail experience that was owned by some wonderful Canadians, Wayne and Ellie Smith from Vancouver, and unbelievably fine people. And tragically, as we had this great experience, we came back, and I then threw myself into what was going on with in our community particularly. But let me just regress and state that as part of what's happened with the destruction of livelihoods, the Zeppelin dive and sail failed. They lost all their customers, and Wayne and Ellie sold their launch and had to raise money, sold all their dive gear, and had to use that money to get back to Canada to find other employment. So it's looking forward to going again with them somewhere else in the Sea of Cortez. But getting back to me and the pandemic, the coming back into the Imperial Valley, the pandemic and the spread had not occurred into our area at that time, and I was watching what was going on in the Northeast, where it was really hit hard, and what was going on in Europe, and particularly France, and that's when I began to research it on my own with regard to what appeared to be the best approach for the treating patients with the infection. And I really admired Dr. Raoult and Dr. Zelenko from New York. And I was so impressed with the efficacy of the hydroxychloroquine cocktail or triple therapy with azithromycin and zinc. And I realized to myself that would be a way of treating it early. And through my 30 years here, I've been the only practitioner for HIV in the Imperial Valley, and I always took an approach of early treatment of HIV, and that has been a very true approach, an effective approach, adopted widely now. And so I felt that I wouldn't want my patients to suffer without an early treatment, and even if it wasn't effective, at least I was doing something, and if it was effective, then they would be helped greatly. So that's how I got into it, and then I joined forces with some of my other colleagues who were approaching it with a similar viewpoint.
So precisely how the protocol came up? It was Dr. Zelenko's protocol, or did you make some modifications?
It was based upon the Raoult protocol, and assuming my assumption was that Zelenko was using the same dosages in his protocol, which was somewhat different. His dosages were lower of the hydroxychloroquine, but that was fine. The Raoult protocol was a protocol that we adapted that involved a loading dose of 400 or 800 milligrams on the first day, and then 400 to 600 milligrams daily for the next 4 days. So the total dose of 2,800 to 3,200 milligrams of hydroxychloroquine in a 5-day period. And the Zelenko protocol involved a 200 milligram twice a day, which is a very conservative low dose and safe dose. It's the same that is given to rheumatoid and lupus patients chronically. And then it was just incorporating zinc and one of the 2 antibiotics, azithromycin or doxycycline. And in looking back at my medical education, I think for the majority of doctors having been educated in medicine, the antibiotics that were selected were never taught to be used as antiviral agents or to be possibly having antiviral action in addition to antimicrobial action, which is unfortunate. And I think looking back on everything, there has been some suppression of information on different medications, including hydroxychloroquine, over many, many years. That and I think it's an oversight or perhaps some other reasons for that suppression. But in any case, that's how I came up with my protocol, and it turned out that it was the same protocol that almost identical that my friend and colleague Dr. Brian Tyson was employing in his urgent care clinic. And Dr. Tyson has been a colleague and friend of mine for many years. We were hospitalists together at our local hospital for 5 years or more. We had great confidence in each other, and when he opened up this urgent care clinic in the city of El Centro for the Imperial Valley, he was not getting any backup support to give him a break. He was working 7 days a week, and for 2 years or more, I would take over for 1 day a week at least, or come down in the evenings to give him a break to rest. And this was particularly helpful when in March and April, and then particularly May and June, when we were getting inundated with COVID-19 patients there throughout the Imperial Valley. And I can say more about how he operated his clinic, his urgent care center, which was phenomenal, if you'd like at some point. I of course continued my practice at the Pioneers Medical Center, a multi-specialty clinic, and I continued to be a hospitalist at our local hospital. So I would see the whole spectrum of patients, from outpatient through inpatient and through the intensive care category, with patients that were on mechanical ventilation.
How were you proceeding to establish the diagnosis for COVID, as there were these issues of testing?
Well, we would base our diagnoses on symptoms, of course, that were presented. Patients presented with the bad flu symptoms, and the knowledge that there was an expanding number of patients being detected positive. As the months evolved, weeks evolved, we had more reliable tests for the PCR nasal swab testing, and the earlier, prior to that, serology testing for picking up patients that were post-acute infection, but it was a combination of trying to use available rapid testing when we were able to do so, or generally it was starting patients on treatment that were highly symptomatic or high-risk patients, and then waiting for the test result to come in to confirm that they were COVID-19 infected. If the test was negative and patients were completely resolved symptoms, we could have them at their discretion stop the treatment that was provided.
Can you tell us about the number of patients you treated and what are the typical profiles of those patients?
Well, in my own clinic with my other providers or colleagues, we treated over 300 patients. And then on the days that I would be at the urgent care clinic, we would see 10 or 12 patients. And so in Dr. Tyson's clinic, that he documented extremely well from the February onward, and there were 1,800 positive patients, high risk, that were treated out of maybe 15,000 that he tested and screened. And to his credit, he set up a very well-organized program for bringing patients in by car, letting them given numbers and the cars be parked and brought in an orderly fashion to have the testing done, and those that were symptomatic were brought inside for x-rays and for further workup and treatment. But it was quite an effort for him, and he deserves a great deal of credit and respect for setting up what should have been set up all over our country to deal with this. And I think he's going to be at the White Coat Summit in Washington Friday and Saturday of this week with other doctors, communicating more on where we are and what can be done to stem this pandemic.
In terms of the demographics of your patients, you see young, old. Can you tell us a little bit about?
Okay, yeah. The population here in the Imperial Valley, it's largely Hispanic population. We're on the border with Mexico, Mexicali, and neighboring Yuma, Arizona, southeast part of California. We have many industries in the area: the farm and agricultural industry, the geothermal industry, the prison system, correctional officers, border patrol, and then general population in other fields of work. And we would initially were dealing with patients that were older adults as well as younger adults, but they were primarily those that in the 50s, 60s, 70s that we would see in my clinic and also at the urgent care clinic, and even some a few older than that. And they would come in generally with the typical bad flu phase of COVID-19.
Things have evolved a bit, I think, in terms of the knowledge of the therapeutic options for COVID-19, and you're very familiar, I think, with the work of Dr. McCulloch and Professor Rich. Can you comment on that slide where you see this slide where there is a real kind of overall protocol for outpatient treatment?
Yeah, I surely can, and that it embodies my approach, yet it's so well stated by Dr. Peter McCullough from Baylor University. And again, I'll never forget the time in late May, early June, when I saw Harvey Risch's wonderful article in the Journal of American Epidemiology recommending early outpatient treatment of infected patients, his work, along with Dr. McCullough and his collaborators, really provide an algorithm that we needed to have stated and presented for not necessarily for me, but for the second line or outpatient care providers around our country and around the world. And what the slide that you're referring to shows is a breakdown of how to deal with these patients, dividing them into patients that are above or below 50 years of age with or without symptoms or comorbidities, and then the employing of, in a sequential fashion, of treatments that are safe and positive for dealing with a viral infection, with the first line of treatment being zinc and probably vitamin D and vitamin C. But zinc is a key component as an antiviral. Once it's intracellular, it has a inhibitory action on the RNA viruses, RNA polymerase. And so actually this protocol it probably will be applicable for influenza treatment and other RNA viruses in addition. But it then goes on to highlight the employing of 2 or 3 possible treatments that should be used, early treatment. And that's the big recommendation that we never got from the Dr. Fauci or the WHO or FDA, and which tragically has not been stated or recommended when it could have been recommended at the inception, initially with the hydroxychloroquine possibility, the cocktail that is described as a treatment for the symptomatic patients or high-risk patients with the triple therapy that, as I've said, that I've used with many of my colleagues here in the Imperial Valley with great success. But it also points out that now there's a growing and very impressive findings with ivermectin, the antiparasitic agent. And that's, as I was telling you before we started this interview, Dr. McCullough sent me a note of treating a very high-risk patient with cardiac disease with ivermectin at the inception, along with azithromycin or doxycycline and zinc. And the studies from Dr. Barodi, whom you interviewed so well in Australia, have backed that as a great agent for this viral infection. And so that gives us another arm, another weapon to employ early on. And I look forward to using that in addition when it's used, it's appropriate. And then the final option is a agent that's used outside of the United States. I've forgotten the name of it, but it's the one that is an inhibitor of the RNA polymerase of coronavirus, and it's not yet available here in the United States. But in any case, so we have 2 weapons, cocktails, and it's again so important to use a combination of agents, not a single agent. They support each other, or synergize in their inhibition of the viral multiplication, and that's the key outpatient principle, to stop the multiplication and prevent it from spreading to other organs, and to prevent the development of the cytokine storm and the COVID pneumonia that is so difficult to treat. And that I saw that in those early months in my hospitalist work, when we were overwhelmed with the infection, particularly June and July, and we had all of our ICU beds taken up and expanded the ICUs in the hospital I've been affiliated with, primarily in the north end of this Imperial Valley. And these were patients on long-term mechanical ventilation, and then many were transferred to higher levels of care for ECMO and for more extensive management of, as best to save their lives. in any case, Dr. McCullough gives a beautiful YouTube presentation of the entire aspect of this algorithm, and it leads to moving on further into other aspects of the management that involve prednisone and corticosteroid treatment. Budesonide inhalation is one I've used that has been very helpful for outpatient management when dyspnea, hypoxia develops and there's a need to counter inflammation in the pulmonary system. The colchicine is also recommended in terms of inhibiting some of the inflammatory process in the pulmonary system or in the chest wall, for instance, if there's a inflammation of intercostal musculature. So we have an evolving algorithm that's going to change as the months go forward, and new things will be added. And I found in some of my patients that I've been able to take care of in the hospital, if I use the HCQ cocktail with budesonide and then convalescent plasma, that helps them recover very rapidly. And the antibody cocktail, the monoclonals that are being developed that President Trump was treated with, are an example of a great advance that should be helpful, but not widely helpful, unfortunately, because there's limited amounts of that preparation or that medication. It's still yet to be formally approved. But the tragedy here in our country and in the world is what the action was taken by the FDA and Dr. Fauci and CDC to stigmatize the only agent that I saw that we could use properly in May, and base it upon falsified data. And it was a disgrace to me that some of that data came from where I was trained at the Peter Ben Brigham Hospital. And I'll never be able to have respect for that Dr. Mayra there for just sloughing off. This is an oversight that he let this information come out and allow the naysayers and the people who didn't want to get an early treatment out there for so many people to ban hydroxychloroquine, or at least frighten doctors that didn't know all the information that they should have known or could have known, and led to it being banned in Western Europe and in the United Kingdom and Canada. It's a terrible story that took place in that regard.